Hello everybody, it's great to see so many people who've joined us for our LKN launch event, and it's so great to see so many friends and colleagues joining. So my name's Kieran McCafferty. I'm a kidney doctor from Bart's Health in East London, and I co-chair the prevention workstream with Linda, whom you'll see later. Next slide. This is the agenda. We've got quite a packed agenda. We're hearing from both secondary care, from our colleagues in primary care, and a little bit about the logistics of what we're asking. And then finally, I think this is key, we've got about half an hour session of your questions to ask us, and we can help try and solve solutions for you. Next slide. So it's 2 hours, a bit of housekeeping. So we really want to hear your questions. So if you've got any questions, don't put up your hand, type it in the Q&A. So you'll see the Q&A boxes at the top of your screen, and you can ask those questions during the talks, and we'll come on to them at the end when we'll go through all your Q&As, and hopefully we'll be able to answer as many as possible. And so without further ado, next slide. It gives me great pleasure to invite Kate to come and talk to us on the forgotten risk factor for CKD and health equity, which she is obviously vastly experienced on.
Thanks very much, Kieran. Yeah, the tech is working. Fabulous. I'm Kate Bramham. I'm a kidney specialist from King's College Hospital, and we work in a area of deprivation and with high proportions of people from ethnic minority groups, and this is a passion of mine. Could I have next slide, please? So I'm going to touch on upon a few issues in this talk, but really kind of focusing on the interplay between cardiovascular disease prevention and chronic kidney disease prevention, and what the new interventions could potentially mean in terms of widening the gap in health inequity, and what we can potentially do about it. And really kind of bring this to primary care to present to you what the challenges are ahead, and hopefully later on we'll be able to discuss how we can address them collectively. Next slide, please. I think everybody is really aware of cardiovascular disease being a major cause of health inequity. Tens of thousands of premature deaths are occurring throughout the UK every year. And the CVD Prevent tool, which I think many of you in primary care are now aware of, is hopefully going to be a useful benchmark to allow us to assess how we're doing in terms of cardiovascular disease prevention. And we're delighted that chronic kidney disease has been introduced as part of that assessment. Next slide, please. But as I said, I think that the novel therapies that we're going to be talking about later potentially have run the risk of exacerbating the health inequities that already exist in cardiovascular disease, and indeed massively exist in chronic kidney disease. There are 3 to 5 times higher rates of kidney disease, end-stage kidney disease in ethnic minority groups, and our socioeconomically deprived communities are much more likely to be affected. And those who end up on dialysis are less able to have employment, and this perpetuates the cycle. So we really do need to be ensuring that our new strategies are reaching these underserved communities. Next slide, please. Next slide, please. Thank you. And as I say, chronic kidney disease has now excitingly become one of the 6 high-risk conditions, and hopefully this is becoming kind of increasingly apparent in a primary care setting about why we need to assess for it and what we need to do when we find it. But again, that's part of the further talks today. Next slide, please. And so what is chronic kidney disease? I suspect that most people are very familiar with this assessment, but just to highlight that we need to be assessing both GFR, so how well the kidneys are filtering the blood, and also ACR, so no longer proteinuria testing. Albuminuria is a really important marker for chronic kidney disease progression risk, and also cardiovascular disease. And at the moment, nephrology services are really dealing down the firefighting end with the in the red, and really our new therapies are going to be able to protect people from moving into that red zone. So we're really now wanting to have greatest impact in those orange and yellow zones, and that's where we need your help. Next slide, please. So why is chronic kidney disease a risk factor for cardiovascular disease? Next slide, please. I love this next slide. It's really highlighting exactly what the kidney is about. It's thousands and thousands and thousands of capillaries, and it's an incredible window into cardiovascular health. Really, the two go hand in hand. Yes, there are some other causes of kidney disease which exclusively affect the kidneys, but further downstream with progression of kidney disease, the whole cardiovascular system gets affected. But the real kind of focus of our work, I think, needs to be on those common risk factors, those with hypertension and or diabetes that we're very familiar with working with. Next slide, please. So we're very aware that people with chronic kidney disease don't die from end-stage kidney disease or chronic kidney disease. They die from cardiovascular disease. And this graph basically highlights that those with the paler pink with chronic kidney disease are much more likely to have cardiovascular disease and die. And that's all causes of all elements of cardiovascular disease that they're affected by. Next slide, please. And this slide shows that with more advanced kidney disease, the risk of cardiovascular disease increases and they're much more likely to die. So this is kind of the core piece of our work in nephrology services, that we attempt to do a lot of cardiovascular prevention, but by then potentially it is a little bit too late, that the damage has already been done. But our patients, as I say, die from cardiovascular events, not necessarily from end-stage kidney disease. Next slide, please. But the wonderful thing is that we have this fantastic marker that not only is an excellent marker of progression of chronic kidney disease, but also an early marker of cardiovascular disease, so albuminuria. So the kidney is starting to leak albumin through increased filtration pressures, and it's leaking into the urine. And as soon as we pick up a small amount of albumin in the urine, that is a red flag, because that not only suggests that there's something going on in the kidney, but there's something going on in the whole cardiovascular system. And potentially there's progression not only within the left ventricle in terms of left ventricular hypertrophy, but all the endothelial integrity through the cardiovascular system is at risk. So this is a real marker for things to come. Next slide, please. And really just to highlight to you, I mean, I think this is really, really compelling, that people, so we're looking at the middle blue, pale blue graph, the bar here. I don't know if you can see my pointer, but these patients who've got relatively preserved kidney function, so that they have got a GFR greater than 75, but they've got microalbuminuria, have a far higher risk than even those who've got a nearing end stage renal disease. So that's the pale pink bar. So you rapidly push down that pathway towards a cardiovascular event as soon as that microalbuminuria appears. If you haven't got microalbuminuria yet you've got a reduced GFR, yes, that's not great. But as soon as that microalbuminuria appears, that is a very, very bad sign. And that's why we're on the hunt to try and identify these people and risk stratify very carefully. Next slide, please. And I think this is, again, very, very compelling. It's the old data, but really just to highlight to you that the combination of diabetes and kidney disease, diabetic nephropathy or diabetic and any sort of kidney disease, is a real red marker again. That they've got the highest risk of cardiovascular disease. No surprises there. But if you compare these people, so the green bar, if you're comparing them with people without diabetes and chronic kidney disease, you can see that actually you're far better off having just diabetes alone without kidney disease than having kidney disease without diabetes. And then obviously the worst group is having both. But actually in sequence of risk factors, diabetes, then chronic kidney disease without diabetes, and then the combination of the two. And I think that not many people are quite aware of how powerful a risk factor chronic kidney disease is for cardiovascular disease. Next slide, please. But we know that actually if we manage to reduce the albuminuria, you can see the slide on the right here. This is an old trial from the renal trial, which was comparing losartan with placebo. If you reduce the albuminuria, you make a difference. And so again, a lovely barometer of cardiovascular health, that there's a reduction in cardiovascular events if you manage to achieve that. So it's a great biomarker. Next slide, please. And again, as I've alluded to, as in the nephrology world, we are completely full at the moment in terms of our provision of renal replacement therapy. It's extraordinarily expensive. So I guess we do have our own agenda as well in terms of trying to reduce the proportion of people that are going to be ending up on dialysis. And you can see as you're moving further left with reduced GFR that the risk of end-stage kidney disease increases. But if you're in the pink bar as opposed to the blue bar, having high rates of albuminuria, that is a really bad sign in terms of progression. Next slide, please. The other thing that probably few people are aware of is the fact that chronic kidney disease is associated with many more unplanned admissions, and particularly in those with more advanced disease. So this is burdening the NHS in terms of cost and resource. And if we can keep people further towards the CKD stage 2, that definitely has cost savings as well as impact on the individual and their family and their communities. Next slide. And kidney disease itself is not just associated with cardiovascular disease, but it's associated with all-cause mortality. And patients who've got chronic kidney disease are much more likely to die. And you can see here, patients with stage 4 kidney disease, 19 out of 100 die annually. So it really is a severe marker of frailty, of comorbidity, and of cardiovascular risk. So it's a useful triage tool in many ways, assessing kidney function. Next slide, please. And again, I don't think people are aware of the fact that once you end up on dialysis, that it is actually much worse mortality-wise than having several forms of cancer. Only pancreas and lung cancer really trump end-stage kidney disease in terms of rates of survival. You'd rather pick to have colorectal cancer than a diagnosis of end-stage kidney disease in terms of longevity. And I think that's a surprise to many people. Next slide, please. So this is the major problem that I'm hoping that people will understand and become increasingly aware of. We're already full in the dialysis units. It's already a horrific diagnosis to have, having end-stage kidney disease, but people with chronic kidney disease are dying premature deaths from cardiovascular disease as well. And this problem is only set to get worse. It's all rather doom and gloom, isn't it? But there's a massive global epidemic of chronic kidney disease. The incidence the prevalence, I should say, is increasing. It's increased already 87% over the last couple of decades, and a further 17% increase is forecast, predominantly driven by diabetic kidney disease. And as I said earlier, that we are very concerned about our underserved communities having reduced rates of diagnosis and potentially less access to treatment, and they're the group that are at greatest risk. Next slide, please. Thank you. And the problem for us in nephrology services is that we're not allowed to see patients until the damage is already done, and it's really a case of the horse has already bolted. And that's why we're really keen to work with you to move upstream to really address this problem early on in a way that's going to save lives, reduce morbidity, and also save cost. Next slide, please. So this is the big problem. We've got this tidal wave heading towards us. We've got lots of preventable deaths. We can't deal with it from the nephrology side because we're not having access to these patients. But as I say, we're really keen to support and work with the new incredible interventions that we're going to talk about later on. Thank you. Next slide, please. So hopefully I've highlighted to you that it's not good to have chronic kidney disease for many reasons. Patients are much more likely to have cardiovascular disease, much more likely to have hospital admissions, much more likely to die, and that we can have concurrent strategies working on cardiovascular risk prevention in those with chronic kidney disease as well, and use kidney function and albuminuria as a barometer and a triaging strategy for stratifying risk, and that if we actually manage to address this, we potentially can reduce these premature deaths. We can reduce health inequalities and the disparity between those cardiovascular risk, but we really need to understand and work out new ways to go out there and identify these patients really early so that we can have the biggest impact. Thank you.
Thanks, Kate. That was absolutely brilliant. and we're going to rapidly move on to our next presentation. So we've heard from secondary care, and now we're going to hear from our colleague in Southwest London, who's the LKN primary care lead, so a GP's viewpoint. Take it away, Vasa.
Thank you, Kieran. Good afternoon, everybody. Thanks for joining us today. Yes, so we heard from Kate. There is a tsunami coming our way. In fact, it's already arrived on our shores. We haven't yet seen it. Next slide, please. So today I'll be going through the Core 20+5 approach, which Kate's already highlighted to us, looking at deprivation, ethnicity, inequality, sharing some learning from Southwest London, learning lessons from the vaccine outreach, what people told us, and then looking at the benefits of changing, and then finally asking ourselves whether we are going to pass the test Hugo Green once challenged us with. Next slide, please. So Core 20+5, I won't spend time on this because you've already seen this slide, but remember the +5 includes the people we normally don't see in hospitals or in primary care, the people who are homeless, the people who are asylum seekers, the people who are refugees, people who are travelers. We really need to understand that we need to learn and find ways of reaching out to these people because they do suffer all the diseases rest of the population suffers from, but they actually have a greater burden of the long-term conditions, undiagnosed, untreated. Next slide, please. So it's a very complicated slide. Don't try to read all of it. I'll just walk you through it. If you live in Southwest London, you probably know this already, but this approach in Core 20+5 allows us to look at the bottom 20%, the most deprived people we look after. And in Southwest London, we have about 340,000 of these people. And in this graph, in this map, we know exactly where those people live. And this is very important. When you look at outreach, reaching out to communities, we need to know who the communities are, where they live, and what are the sub-characteristics of these individual communities. And then we can tailor our message, not only in language, but also in culture, because individuals have their own private culture, they have their own lifestyles, and unless we address people, meet them at a point they understand what we're talking about, we actually can't change behavior. We have to explain to people what matters to them, find out what matters to them, and then motivate them for the lifestyle changes and the management plans we come up with so that we can get maximum benefit of all the science we know. It amounts to nothing unless we meet people where they are and work with them. Next slide, please. So if you dig deeper into the Core 20+5 approach and find out who the core 20% of your most deprived population is, you also can find out where they live. So if you look at Southwest London, you realize that 50% of our core 20 population lives in Croydon. We also know the ethnicity distribution of this, and we must not forget that 48% of our core 20 population in Southwest London are actually white. So we need to be clear that we look at the evidence. We are not driven by ideology, we are driven by evidence. And if you look at the evidence, we know where people are, and then we meet them where they are and try to improve their lives. Because as Kate said, once you get end-stage renal disease, your life expectancy is reduced, but also your healthy lifespan is reduced. So if you look at the core 20 population, the healthy life ends, if I was one of them, 3.5 years from now. That's not fair at all. So if you focus on life expectancy, you might think there is not much of a difference. But if you look at healthy life expectancy, there's a massive difference. And this is what this is all about, treating people with all long-term conditions, the vascular ones in particular, and CKD as well as part of that, if you just heard, if you want to increase people's healthy life expectancy. Next slide, please. So, vaccine outreach. When we looked into this concept of vaccine hesitancy, and when we spoke to people we had never spoken to before, when we met them in places we had never been before, the resounding message back was that they actually want change. They want to change, but they also want us to change. And if you look at the data and if you look at what's going on at the moment, if you don't want to have dialysis units without any beds, if you don't want to have coronary care units without any beds, if you don't want to have stroke units without any beds, we have to start now, not tomorrow, today, to start looking at CKD as a vascular condition and treat it But to do that, we can't carry on treating people the way we treated them before. We got to have much more robust call and recall systems. We got to learn to go after those people who don't give us the early morning urine sample. How do we get that? How do we make it easy for us to obtain that sample to test for ACR? These are the things we need to come up with in the next few months if we want to make a change. Next slide, please. Now, we all know the story. We have always learned it in medical school, in GP training, about the rules of halves. But we can't go on talking about the rules of halves. We have to look into the fact, why is it that we struggle to diagnose these conditions? Why is it that we struggle to treat them? Why is it that we struggle to treat them to target? And unless we achieve all this, we can't make much headway, and we can't increase that healthy lifespan of those people who are most affected by this. Now, if you want to develop your CKD register, we really can't start at CKD. We've got to look at our population. How is our coding for ethnicity? How is our coding for hypertension? How is our diagnosis for hypertension? We've got to deal with our diagnostic deficit. How is our treatment for hypertension? Do we reach the treatment targets? Same with diabetes. We've got to look in the mirror. What are we doing in our practice? What are we doing in our PCN? What are we doing in our borough? What are we doing in our region? Are we obtaining that urine sample from people with diabetes to find out, have they got diabetic nephropathy? How is our treatment target going? Are they all on lipid lowering treatment? Are people with diabetes, is their blood pressure adequately controlled? And unless we achieve glycemic control, blood pressure control, and lipid lowering, we are storing up trouble downstream. And again, our obesity register. What are we doing to the people? We diagnose obesity. How are we allowing them to obtain weight management plans? How are we writing these weight management plans? How are we developing these weight management services? Are they culturally sensitive? Are they practical for people who are struggling to make ends meet? Now, we're going to do all this as part of the vascular agenda. And of course, CKD. We know that at the moment, we are diagnosing it late, and we know that people from minority ethnic backgrounds are diagnosed later, and also they progress faster. So there's a lot of work to be done. Next slide, please. But this work to be done is beneficial across many agendas. If you look at a population health agenda, if you look at clinical outcomes, if you look at system outcomes, if you look at economic outcomes, this is work well worth doing, because if we get this right, we actually help the inequality agenda. We reduce we reduce adverse cardiovascular outcome. We develop neighborhood teams. We work with local health authorities. We reach out.
Apologies, we might have lost Vasa. We'll just give him another 30 seconds to try and dial back in again. If not, what I would suggest we do is, we're almost at the end of his slide, so I think if we just put on to the last slide, his summary slide, just the next slide. So I think Vasa really set the scene really well, from a primary care point of view, about the need to understand our population and really target our inequalities, which in London are particularly important. We need to engage with the greatest people who are at risk of CKD, not perhaps the easiest people to get, but the people who are at greatest risk. And we need to both detect and optimise treatment for these high-risk groups. And I think the rest of our talk today will really be about identifying and how do we manage and optimise our high-risk groups. And I couldn't agree more, and we'll come on to this later on, that the time to act is now. And so with these talks ringing in our ears, I think the most important person we have to talk is next. The reason why we're all here. If we get to the next slide. Is the patient's perspective, and how at the heart of all this, how the patients are why we're all here. And so I'm really delighted to have a pre-recorded talk by a patient living with diabetes and kidney disease, Khalda Moosa. Next slide.
I'm born in East Africa in Kenya. I have mixed blood. My father is from India. His blood is from India. My mother blood is from Arab, Oman. And I'm the 5th generation. I came in this country because after independence, whatever the agreement between the British and Kenyatta, it didn't work. So Kenyatta asked us to leave the country in 24 hours. Wow. So it was very, very difficult for living so many years with a big family, so many people, you know, never lived alone, and coming in this country, and it was fog, all the houses, they look alike, and the kitchen is like that, and it was very, very difficult. I was very healthy, because in Africa, I come from a very big family, very healthy. I never, ever, ever, that's a mistake I made, that I will become sick like that. But when I had a menopause, then I started having a problem. Like I had blood pressure. Then I came to know about my GP, told me I'm diabetic. That's all, I'm a diabetic. Nobody told me when I was diabetic that I'll get a kidney disease. Dr. Edlin, before that, every year I go to clinic. Then if she is the only one, when she takes blood test after 2 weeks, then appointment. Then she tells me, your cholesterol is like that, your this is. So she's the one educated me, what is in my blood. I never knew about that. Then she told me, your kidney is low. But she said, don't worry, I have contacted the kidney people. And when I went again, she said, they say it's okay, they're monitoring, it's okay. But she's the one who is telling me, your cholesterol is up, your blood is like that, your thyroid is like that. So I get all information every once a year from Dr. Edlin. Many things contribute to the... You see, why people are paying so much money, spending? Alhamdulillah, alhamdulillah, we are much better than any part of the world. But you're not doing it properly. You know, if you put the system properly, the doctor also can be having it, you know. Why are you giving a doctor 10 minutes? Everybody is not 10 minutes. They are patient. Of course, some people 10 minutes. But don't count everybody in one box. And I don't tell my family things. I don't tell them. Because I don't want them to worry, because they're all like me. My sister in Canada, my sister in America, only one blood that left. I don't like to complain, why I'm sick. I don't talk to my friends also now, because I feel embarrassed every time. How are you? I'm not well. You see, I stopped talking to people now. So I'm isolated. All I do, I sit down in front of TV. It takes my mind away. As it is, your kidney are going to get weak. You see? The diabetic people, person who is got a diabetes, they should educate them very well, you know, about the eyes, about the hands, about the leg, about the kidney, about the heart, you know, because with the diabetic is a slow killer. It's because people say cancer, you know, but diabetic, straight away you get heart, you get blood pressure, because it will go together like that. So they should, like for heart, you get this and that, what to eat, what not to eat, how to live the life, how to do exercise, how to avoid this, how to avoid stress. You know, all these things, it would have saved a lot of time. And people, of course, some people are healthy, naturally, and some people are not healthy. Their hormones and their body is, because their genes, whatever. So because of their genes, there's a problem there, you know. But you cannot prevent it completely, but you can slow it.
That's a really crucial point.
And can give a person hope. Can give a person, you know, Then it depends on the person whether they're lazy or they don't. But there is a path there. It will slow down. So when 50 miles an hour, you will go 10 miles an hour. So you've got that distance to enjoy it or to do something, you know, discipline yourself.
Fantastic. I'd really like to thank her for giving us her insight into what it's like living with chronic kidney disease. I think, you know, to summarize what we've learned is we need to educate patients with CKD generously and early. So spend time telling them and talking to them about their CKD, even though this can be quite challenging and may not be the easiest conversations. I think we would all agree that living with chronic conditions can affect people's quality of life and life participation hugely. And I think this is a beautiful statement that she had. So patients, clinicians can work together to slow down progression to 10 miles an hour, not 50. And I think if we look at the huge number of landmark trials in diabetic kidney disease in the last 5 years with renal endpoints, it is exactly that. It's slowing down progression from 50 miles an hour to 10 miles an hour. So fantastic. Next slide, please. So
thank you for the
carry on, Neil.
Thank you for the invitation to speak to you today. My name is Dr. Neel Basudev. I'm a GP in Lambeth, Southeast London, and I also work as the LK and GP lead for Southeast London ICS. I'll be talking to you about some of the work we've been doing at the London Kidney Network around CKD prevention and particularly on early identification. So in order to sort of set the scene, I'm just going to highlight some of the issues which I'm sure many of you are well aware of in terms of CKD prevalence and identification. We know, for example, that blood tests for disease types such as type 2 diabetes and hypertension are relatively well performed compared to urinary tests. So urine tests and ACR capture is always a sort of a lower benchmark compared to blood tests, and that also overspills into coding of this as well. We can see this very clearly from recent data. So, for example, looking at the National Diabetes Audit, an 8-care process completion, you can see at the top of the bars here that urinary ACR capture is always the poor sibling of all the other diabetes 8-care processes. So, and that's not just seen in this most recent cut from 2021, but for virtually every year, ACR is always the sort of lower achievement. And in terms of coding, we know that there are many people who are uncoded or poorly coded in terms of CKD. So there's a lot of work and tidying up to do in terms of coding. So not only are we not detecting enough CKD, the CKD that we are detecting is not being coded well enough. And in terms of some local data, this is just showing sort of RAG rating or red, amber, green rating from a population needs health assessment that we did locally for all the ICSs. And this is broken down by PCNs, and I've just shown my PCN there highlighted in Lambeth. And what you can see here again is just a lot of variation. You can also see that we can break down some of the data, not just by coding and outcomes such as care process completion, but we can also look at prescribing. So, for example, statin prescribing, ACE and ARB prescribing as well. And again, it's been very helpful to look at some of this data and really then give us an idea of which PCNs and which areas to really sort of focus in on. So those are some of the issues that we can see both nationally and locally. And in order to tackle a lot of this and improve CKD prevention, we've established the London Kidney Network. This spans the 7 main adult renal units across 6 ICSs, that's 5 in London and Surrey, and accounts for over 25% of national renal activity. This slide, I think, gives you a bit of an idea around how the LKN looks and works. So the LKN, as I explained already, is made up of the acute units, These acute units sit across all our ICS partners. We also collaborate with other London kidney network, clinical networks such as the Diabetes Network, which I'm also a part of. And we also have a strong collaboration with some of the other academic health science networks in London, such as Imperial, and data repositories such as Discover Now, and other research institutes such as NIHR, and best practice with NICE. We also collaborate with important charities such as Kidney Care UK and Kidney Research UK. And finally, we also work alongside some of the local clinical effectiveness groups, such as the one that I work most closely with in South East London. So we have a multitude of partners and collaborators who really allow us to start tackling some of the issues around CKD prevention and early identification. In terms of the London Kidney Network's structure, it's made up of a board, and under that board sits various sort of management teams. So for example, we have various primary care clinical leads, such as myself and other colleagues who work across the different ICSs in London. The management structure then oversees the work streams. There are lots of different work streams, all tackling something different and very important in terms of sort of kidney structure and improvement, and the CKD prevention is one of those work streams. And underpinning these work streams, we have all these different expert advisory groups, such as Health Equity, who help provide some of the advice and sort of QI into these work streams. CKD prevention, just to give you an idea around how this is broken down, is broken down into an early identification subgroup, which is where I work, and then that moves into other important parts of CKD prevention, such as preventing progression, which is where you'll hear shortly from Dr. Shaw. In terms of the main aims and objectives, I've just highlighted some of the key aims here. So one of the main key aims is to obviously identify and manage CKD early. And also there's a strong nod towards some of that variation that you've seen, for example, on that RAG rating that I showed you earlier. And we also want to support the appropriate use and expansion of SGLT2 prescribing for people with CKD. The objectives really are around identifying risk factors and detection, and doing the appropriate recording of CKD within primary care, and dealing with a lot of this unwanted variation. And then we have various outcomes here. So for example, in people with type 2 diabetes, we're aspiring to have more than 80% of those people having their ACR tested within 12 months of the various support packages that we have in place. And if you compare that to where we are now in terms of ACR capture, that's sitting at around the sort of 50% mark, as you've seen earlier. Really the focus has been around establishing a clinical pathway for early CKD detection and management and follow-up of that. And I'll show you that pathway now. So what we've done with our pathway is really use very clear language, and we've tried to keep it all on one page so that it makes it sort of easier for people to follow in terms of what needs to be done, what cohorts to work with, and how we can improve early CKD detection. So the kidney health check is mainly focused on people with diabetes and hypertension, and that's primarily because diabetes and hypertension already have very well established registers. They have very well established systems within primary care, so it makes them quite good and natural target to work with in terms of having the systems in place. So we sort of explain what a kidney health check is, and what you'll see through this flowchart is the importance that we're giving to urinary ACR, so that we are saying that urinary ACR is as important as GFR, and that it's not detecting and managing CKD is not all about GFR and blood tests. So the importance of urinary ACR is highlighted at every step of this pathway. We point to who should be having a kidney health check. So as I said, we're starting really with people with diabetes having a yearly check, and those with hypertension every 1 to 5 years. And then the first step of the pathway is sort of putting together the kind of 3 main groups, if you like, of people in terms of their urinary ACR, whether it's less than 3 to 70 or greater than 70 there, and indicating the significance of these. Following the flowchart along on the left side, those with a lower ACR of less than 3 would have their blood test done for their GFR, and if their GFR is less than 60, then they go down into the box at the bottom, which shows you what people should be doing. So that's to inform the person that they have chronic kidney disease, explaining what chronic kidney disease is, doing the kidney risk failure equation where appropriate, and adding coding. And the coding there is recommended and suggested in terms of coding appropriately for the different CKD phenotypes, and also the importance of albuminuria going into people's records and notes. And those with slightly higher ACR, so either 3 to 70 or greater than 70 group, would have their GFR checked, and again flow down into that flowchart. So that really is how the early detection flowchart works, and this is something that we are working closely with colleagues and collaborating with, such as the clinical effectiveness groups, to put this kind of flowchart, which is sort of clear and concise, into sort of wider circulation, and also design some of the learning packages that will go with this, and some of the coding packages and searches and so forth that will go with this, so that the CKD detection and CKD coding is improved. And from here, we'll then move on to CKD prevention. Thank you for listening.
Thanks, Neil. That's absolutely fantastic. So we're moving swiftly on to catch up. But just before we do, just if anyone has any questions, I know we're throwing a lot of information at you, but if anyone has any questions, just stick them in the Q&A box and we'll get to them after the talks. Kat, take it away.
Thanks so much, Kieran. Thanks, everybody. And hi, my name's Catriona Shaw, and I'm a kidney consultant at King's College Hospital. And I'm delighted to be able to spend the next few minutes discussing more about CKD optimisation and the work in this part of the LKN programme, and also the 3 key actions within 3 months to save lives. Next slide, please. So we've heard a lot so far about the risk of CKD to the individual and to the population and to our health economy. We've heard about the importance of being able to identify those at risk early and how we can start to think about doing that. And we also need a systematic and standardised approach to delivering evidence-based care pathways, including medicines management, to our community. We've known for a long time that RAAS blockade in patients with CKD is beneficial in terms of long-term outcomes, and that's above and beyond the effect these medications have on hypertension management, for example. We also know, and we've seen some data earlier on around about inequity across the sector, and from other sources as well, such as the CKD audit and other real world studies, that there's huge unwanted variation in prescription practice and delivery of such evidence-based medicines such as ACE and ARBs. I think it's also an interesting fact that in CKD, there hasn't been a new group of medications licensed in CKD for improvement in outcome since 1997. It's quite a long time ago, but I'm pleased to say that that era is over, and what a game changer it potentially is. Next slide, please. And so the medications I'm referring to are SGLT2 inhibitors, which I'm sure you're all very familiar with and have prescribed in lots of different circumstances, including diabetes, over recent months. Just to look at the data briefly, again, I'm sure you're all very familiar with this in terms of CKD, but the two pivotal trials to reference for today are Credence and DAPA CKD. And what did these studies show? These studies showed that in patients with proteinuric kidney disease, in those with type 2 diabetes or in those without type 2 diabetes, that SGLT2 inhibitors work. They reduce the risk of cardiovascular and kidney dysfunction, decline, and death, and the really impressive outcomes. So if we just look briefly at Credence, so the primary outcome was doubling of serum creatinine, development of end-stage kidney disease, or death due to cardiovascular or kidney disease, so a composite outcome of kidney and cardiovascular health. And the hazard ratio was 0.7 for those taking the SGLT2 inhibitor compared to placebo, a relative risk reduction of 30%, and a number needed to treat of 21. And in DAPA CKD, where you had patients who had diabetic kidney disease, so type 2 diabetes and albuminuria, and also those with albinuric kidney disease that wasn't related to type 2 diabetes, we had a similar really substantial reduction in hazard ratio of almost 40% relative risk reduction, with a number needed to treat of 19 for the primary outcome. These are really impressive. And I think we have an imperative to use this data, to use this opportunity to look to improve across our entire CKD management pathway. Next slide, please. And that's what the London Kidney Network Chronic Kidney Disease Optimisation Subgroup have been focused on. Next slide, please. So who are we? We're a multidisciplinary team of primary care, diabetologists, kidney doctors, pharmacists, amongst others. And we set ourselves the objectives to develop and implement a clinical pathway to support primary and secondary care in appropriate prescription of SGLT2 inhibitors in, first of all, people living with type 2 diabetes, chronic kidney disease, and albuminuria. And secondly, in people living with chronic kidney disease and albuminuria without diabetes. And our primary outcome, I mean, this is a process measure, it's a surrogate measure. We're looking to see if we can increase the prescription of these medications appropriately. And just to reiterate, we're looking to use the SGLT2 inhibitors as a lever to look across the entire care pathway of chronic kidney disease, including other evidence-based medicines, including ACE inhibitors and statins as a comprehensive care package. And we're looking, as we've mentioned from the outset, to reduce unwanted variation across our network. And we will see, if we can get this right, we will downstream see the clinically important outcomes, the reduction in the rate of incidence of progression to end-stage kidney disease, the reduction in admission rates with kidney and cardiovascular morbidity, and importantly, a reduction in the risk of kidney and cardiovascular mortality associated. Next slide, please. And so what did we see our task as? I think importantly, we wanted to try and distill out as clearly as we could and as simply as we could what the asks and the key actions are around these medications and the care pathways. And I think one of the important things, and I think this has been alluded to by Vasa and Kieran and others so far, and it was prevalent in our discussions as a team from the outset and really continued to have consensus throughout, was focusing on timeliness of prescription and medications in particular. And so you will start to see this repetitive theme across all of our pathways around 3 key actions within 3 months to save lives. I know I've certainly prescribed an ACE inhibitor in the past and then latterly seen the patient several months later and realised that the medication needs to be optimised. I think as a healthcare community, we need to do better. We need to use this opportunity to shift our standards. And so first of all, we have, what are the 3 triggers to think about SGLT2 inhibitors in adults with chronic kidney disease? And we've got albuminuria up there front and centre. We've got type 2 diabetes and we've got heart failure. And for the purpose of today, I won't discuss heart failure any further. Next slide, please. So then we look at the patient subgroups. So first of all, we've got in adults with type 2 diabetes and chronic kidney disease with albuminuria, and the UACR here is 3 milligrams per millimole or more. And we've got 3 within 3 key actions within 3 months to save lives. And so we've got action 1, month 1, maximum intensity RAAS blockade. So if they are on an ACE inhibitor or an ARB, let's maximize that dose to what can be tolerated. If they're not on an ACE or ARB, let's get that started and maximize it. And we would propose as a network that we should set ourselves as a healthcare community a time framework for this. And we want to nudge and suggest that we should be doing this within a month. We've also said that please look to see if the patient is on a statin and start one, and if they're not, unless contraindicated. And that's again thinking about this entire pathway of levering improvement across CKD and CVD care for these patients. Action 2, month 2, initiate an SGLT2 inhibitor according to license with appropriate patient information, an opportunity to speak to the patient clearly about the rationale for the medication, as well as any potential side effects that need to be considered. Action 3, month 3, initiate further blood pressure agent to target blood pressure. This is obviously going to be an ongoing care requirement and care issue. And there's lots of guidance around the different types of medications that we can use to help facilitate this. Next slide, please. Now, we recognise that's obviously quite high level, and so we have produced a more detailed guidance and infographic to help support that headline kind of set of statements. And this chart has more information, more detail around about specific medications and doses that we would advise and suggest, and appropriately and importantly, links to the relevant guidance so that you can see that it's all embedded within good practice, evidence-based guidance. Thanks so much. Next slide. Thanks. And then we've got the other patient group in adults with albuminuria without type 2 diabetes. And you'll see here that the urinary albumin measure is slightly higher. It's greater or equal to 22.6 milligrams per millimole. And we've got 3 within 3. We've got 3 key actions within 3 months to save lives. And look, they're exactly the same. We've got action 1, month 1, RAAS blockade. We've got action 2, month 2. We've got SGLT2 inhibitors. And we've got action 3, month 3. We've got blood pressure optimization. Next slide, please. And mirroring our previous pathway, again, we have the more detailed guideline to help support implementation. Next slide, please. Thanks. So we know what the risk is. We know who we need to identify, and we know what we need to deliver. Most importantly is the question how. With that, I'm going to hand over to my colleague Linda, who's going to tell us a little bit more about our thoughts about implementation. Thank you very much.
Thank you, Kat. Very, very interesting. So, hello everyone. I'm Linda Tarm and I co-chair the LKN CKD prevention workstream along with Dr Kieran McCafferty, who is chairing today. And my role is to help lead and manage our workstream to make sure we're on track to achieving our aim, and that's supporting primary care to identify and manage CKD early. So how exactly are we going to do that? And that's what I'm going to cover in the next 10 minutes. But first, I just want to give another quick overview on the LKN and what we're actually here to do. Next slide, please. So the key messages from the slide are our aims, which are at the top left, and these are to improve population health through quality and outcomes, improving health equity and patient experience, and ensuring value and cost effectiveness. You can see on the right-hand side that the core purpose of the LKN is to define what good looks like, highlight variation, develop strategy, and support delivery of improvement. As Neel said earlier, we cover 6 ICSs, which includes 32 London boroughs and Surrey Heartlands, and 7 renal units for all of London. So we have 6 work streams, and CKD prevention is one of them, and we have 4 advisory groups. Next slide, please. So we've heard from our clinicians about why it's important to identify and manage CKD early, what we need to do about it, and what the pathways look like. So now I'm going to talk about the next steps by giving an overview on what the LKN is doing together with primary care to help identify and manage CKD early. So we've seen these 3 brilliant pathways that we've developed over the past year with multidisciplinary clinicians from across London. Our biggest challenge now is how we support primary care to implement these pathways locally in London and Surrey so that they're actually being used and make a difference to patient care. So the first thing we would really need to do is to understand how implementation works in each ICS. And to do this, our next steps will involve working with local teams, such as the ICS training hubs, clinical groups, and medicines optimisation teams. But in addition to working with local teams, we also need to make sure that we have the right skills and tools for large-scale spread of our pathways. So what we've done is we've organised for our South East London colleagues in the prevention team to attend a training event on how to scale and spread, with a view to then rolling out our learning to the rest of London. So last year, the LKN achieved NICE consultee status, and what that means is that we are an official stakeholder for NICE guidelines. And we did this so that we can help shape recommendations for CKD care, which then supports primary care. So number 2, we're collaborating with ICSs and supporting them with developing and delivering their prevention objectives and plans. And in South London, we're developing CKD pilot proposals. In North West London, we're collaborating with Imperial College Health Partners and the Discover Now team to redesign the CKD care pathway, and we'll also be evaluating the effectiveness of those changes through health economic modelling. And also, as part of our collaboration with North West London, our leads for the LKN Patient Partnership Group are working to involve patients by actively contributing to the planning and the design and the delivery of patient involvement activities. So number 3 is the local kidney networks or programs. So we're working hard with every ICS to set up and support local kidney networks or programs so that we actually move beyond having just a small number of enthusiastic primary care clinicians. Because what we do know is that successful delivery comes from having local structures and local accountability. And that's what we're supporting in each ICS, bearing in mind that it will be different in each area. So number 4, what we're also doing with primary care is exploring opportunities to develop a harmonised data strategy for CKD using existing data sets across London. And we're also looking at what a primary care CKD dashboard might look like. We're exploring how the data for CKD is aligned with CVD, diabetes and other long-term conditions. And most importantly, we'll also be looking at how ICSs will be developing their data locally so that we can work out if it will meet the needs of our CKD pathways. Number 5 is the resources package, which Neel referred to earlier. And what we're currently doing is collating a package of resources for sharing that could be adapted locally to create support or educational packages for primary care. So this package will include resources for clinicians and patients and other pieces of work for sharing across London and beyond. And within the LKN, we also have a group working on CKD coding guidelines in primary care, and we'll also aim to include that in our resources package. So number 6, we are collaborating with the National RSTP or Renal Services Transformation Program. And that's to make sure that we align with their CKD recommendations as much as possible, because we know that the RSTP's recommendations are going to go out to commissioners. So what we don't want to be doing locally is something that's fundamentally different to the national recommendations. And we also plan to share our work at national level to support new renal networks across the UK. And we've already started engaging with our other renal networks across the country to see if there's any collaboration or learning opportunities. And I have to say that as a work stream, we're also learning from others, including the Black Country Prevention Project. So our work that we're doing is developmental, and we do adapt it as we go along. So in the last 8 minutes, we've covered what we're doing with primary care to help manage and identify CKD early. And we would absolutely love it if you joined us on our journey. So what do we do together now? So our key asks would be, please spread the word about our pathways. Talk to your colleagues. Please email us if you want us to come and speak with you. And please do get involved with your local kidney network. And you can contact us for more information about that. So I'm going to stop there, and I am going to hand over to the next person. Thanks, Kieran.
Thanks, Linda. Fantastic. So I think, we've heard a lot of amazing talks today, but I wouldn't want you to go away thinking that it was just the people who are speaking. We're incredibly grateful to almost 100 people across the fields of, primary care, diabetes nurses, patients, carers, pharmacists, nephrologists, diabetologists, who really put a lot of work, and we've thought a lot about this guideline, and we're really proud of it. And I would just like to thank everyone who's been involved either directly or peripherally in our journey so far. And so, it's been a fantastic journey so far, and there's more to go. Next slide. So now it's over to you. We've spoken a lot about. I'm sure you have lots of questions, and I'd like to hand over to Andrew, who's going to chair the Q&A sessions and grill us all on the things that we've said. So just reminding everybody, if you just type in the Q&A function on the top of your Teams app to ask any questions. Take it away, Andrew.
Thank you, Kieran, and can I thank all of those fabulous speakers and the organisers. But this is really about our audience, because our audience is predominantly from primary care. What I would hope we will do in this question and answer session is to start to take that approach that has been described. We need to recognise people at high cardiorenal metabolic risk, people with renal disease early, and get them optimised. What I hope we'll do is that we'll think a little bit more practically for primary care in this question and answer session. And what I want to ask, and perhaps this is, I don't know if that, I'm hoping Vasa is still on and can hear me, but the first question I would ask is, where should primary care be looking to maximise their impact on CKD? And is there any facilities, utilities, or any advice you can give primary care practitioners on how to do this? Is Vasa still there? Otherwise, I'm going to go to Kat. Did you hear that question? Sorry, I know that it's really wet. You told people what they should be doing, you and Linda and the team, but where should they be looking to get the maximal impact on CKD? And do you know is there that might help them do that?
Thank you. I think I heard most of it. I think Vasa might have just joined us as well. And I sit on the secondary care side, but I've obviously been having lots of discussions both locally and across the network about how to try and do this. We've emphasised a lot about urinary albumin creatinine ratios and testing for albuminuria. And I think within our localities, as Vasa was implying, trying to understand what the barriers are to reaching out to people to get the testing done, especially in those that we know are high risk. And that is going to need to take local development and strategies, I think, both from primary care and secondary care, and our commissioners and looking carefully at our pathways. I think for me that I'm a bit of a kind of coding nerd, sadly, and to Neil's point around about coding in itself is not the be all and end all, is it? But there is data to support very much so that coding is associated with better quality care, and it's intuitive, it makes sense. It means you've identified the person. They therefore are then going to be in the system in terms of our pathways, etc., and our automations that we can consider. So I think there is work again for each of us locally to look at how we resource and improve coding once we've identified people. And for me, as a network, one of the things I think is really important is agreeing how we're going to code people so that we're all doing the same things. So apples are, measured as apples, etc. And I think in terms of delivery of the optimization aspects, the medications in particular, although I recognise that's not the whole pathway, that it's much, there's a much more holistic approach to long-term condition care. There is some real meat on the bone, I think, in terms of how we're prescribing those medications, the accessibility to them at the moment. So again, talking about my own locality in South East London, prescribing dapagliflozin for the indication of chronic kidney disease with albuminuria needs to come from the nephrology services, is red listed at the moment. So I think as a healthcare community, we need to work across all of those sections together, and it's going to take a lot of work and it's going to take a lot of energy.
I don't think it's red listed across the whole of London.
No, I said just in South East London.
Yes.
Sorry, in my area.
Okay, well, that brings us on.
Andrew,
I don't know if anyone else has any comment to make.
Andrew, can I come in back on that, Kat?
Yes, please, Vasa, because it's really important to hear from primary care.
Kat, in the past, people did think coding was nerdish, but actually COVID taught me never to say that ever again and never accept that ever again, because I need to know who my bus drivers are. I need to know who my minicab drivers are, because if pandemic comes back again, I'll be calling them and saying, get your mask on, mate, right? So because we knew they suffered badly during COVID, because we didn't know who they were, we could go and give them proactive advice. Same with people, say with poorly controlled diabetes. We need to code, we need to know these people. We need to then proactively chase them up and be willing to meet them in a place they are able to meet. So I think the days where our GPs or anybody else could say coding was a hobby for the nerds, those days are long gone. Now we need to accept that unless
I take that, and I also should be picked up because I should have said, Kat, you are not a CKD coding nerd, you are a CKD champion. But that's
thank you.
Kieran, can I ask you?
Andrew, one final point, please.
Yeah.
One final point, Andrew. If you want to do long-term conditions properly, you need to have a robust call and recall system. If you want to have a robust call and recall system, you need to have coding. If you had coding, you can do automation. If you did automation, half your challenges in LTC call and recall done through automation.
So the message to the audience is to go back and look at where they are with their coding so they can use such a recall system. Absolutely. Kieran, can I ask you? And I know this is again, everything's really about what's going to happen in primary care, but it's two questions in one. One is, in implementing this 3 and 3 proposal, what do you think primary care are going to find the most challenging? And it comes to a question we've been asked from the audience. I think it's quite pertinent, which is appreciating that there is evidence to increase the uptake of SGLT2 inhibitors, but should maximal ACE and ARBs be achieved beforehand? So I'd like if you could sort of encompass the two and then we get the other comments. What is going to be the most difficult? And I'm sort of preempting your answer. What do you think about maximisation of ACE and ARBs?
So what I would say is, listen, I totally know it is primary care under so much pressure, and we wished we could introduce 3 within 3 back in the days when, you know, the healthcare wasn't as stretched as it is now. And I really want to say that we're here to support primary care to make it as easy as possible. We don't want to be here, you know, saying that you've got to do all this extra effort, because we totally get it. So what we're trying to do is this, you know, I don't expect everyone in primary care tomorrow or at 2 o'clock today to change their whole way. I understand that things are really tough. We're trying to make it as easy as possible to do the right thing for patients. So what I would say is, I suspect, you know, and the things that we've said through a lot of, you know, consultations with primary care is, you know, workload. It's thinking about who in your team in primary care can do the things that need to be done. It doesn't always need to be done by a GP. So thinking pragmatically, can we get practice nurses? Can we get community pharmacists? Can we get healthcare assistants to do all the tasks that maybe don't need to, that are, you know, don't need to be done by, you know, GPs who are incredibly stretched. I know the practice nurses and pharmacists are always probably stretched as well, but think more broadly about how can we agilely answer the question. Always bearing in mind that ultimately down the line, if we stop people getting sick, if we stop people getting heart failure, cardiovascular disease, chronic kidney disease, we won't have to spend the time later on in, you know, 2, 3, 4 years looking after them. So I would like to think that looking forward ahead, we will save everyone time. I know that's a hard argument to make at the moment, but please bear with us, and that we don't expect 100% of people to do this right now. In terms of ACE, yeah. So the other thing I would say about ACE, increasing ACE doses, we all know that it will cause some people to worry about potassium, and that's right, and some people to worry about change in creatinine, and we always worry about the people whose creatinine, you know, goes up, or whose hyperkalemia, who run the risk of problems with their heart. But we forget about all the patients who aren't on optimized therapy, who have increased risk of cardiovascular disease, increased risk of heart failure, increased risk of strokes down the line because they weren't on optimized therapy. So it's really important that it's always the things that we do that we worry about rather than the things that we don't do. So getting people on optimized therapy, despite it having some worries about, you know, potassium and creatinine, and we're here to help you. We're here to help primary care. This is what we do as kidney doctors: help with potassium and creatinine questions. So we are here to help with those questions, with that support you need, with the reassurance, with the permission, and our guidance is really, you know, around RAAS optimisation, not starting at Rammerpool of 1.25 and then go up to 2.5 and then go up to 5. Really robust up titration, because patients can't wait for the months and years it takes if you do it very, very slowly, and ultimately the risks are the same. And I'm sure there are hundreds of other barriers that we don't know exist yet when we run this out in primary care, and we are here to help that with those unknown unknowns.
So thank you, Kieran. I think that it is really important that we articulate the fact that this isn't going to be easy, just as you have, and that we're here to help, and we want to help. There's a lot of questions. I want to just go through some of these. There's questions particularly on ACR, and 2 questions I want to ask. I don't know if I could start perhaps with Kate. Is she there? On ACR, would we need to be reintroducing urine ACR for people with diabetes? But then with that, the challenge with ACR is getting patients to provide early morning urine. Could urine sample patients, I don't know if you could provide some advice and assistance on that question, those 2 questions.
Good questions, and we are trying to be as pragmatic as possible. And obviously, yes, it'd be wonderful to get everybody to do an early morning urine, but really we just want to know if somebody's got protein in their urine, and then we can move forward. So the ACR testing in people with diabetes is yes, important to risk stratify. It's not essential in terms of starting dapagliflozin now, yes. Sorry, no to early morning urines. Just any wee will do is what we're saying. We're also very keen for people not to be given false reassurance, I suppose, by getting people on an ACE inhibitor and their albuminuria improving, which it should do. We still need these people to be on dapagliflozin. We're still keen to get them on an SGLT2 inhibitor because that risk is still there for them. So we're kind of keen to do the whole pathway and not to stop halfway through just because the ACR has got better. Hope that's answered your question.
That's perfect, Kate. Linda, there's a question about how do we get these pathways presented to local prescribing and clinical committees? I suspect that's something that we can help with. I don't know if you want to give some insight into that.
Yes, thank you, Andrew. So, yes, I mean, we will be, so in North East London, for example, I'm reaching out to them, seeing how we can support them, but we do need to know how to implement in different ICSs, and it is going to be slightly different. And it's amazingly different. It's across all the ICSs. But if you need some support in terms of, oh, I need the data around, I need the population numbers for the costing, what would you say clinically in this sense? We can put people in contact in terms of helping provide the support, and we can also point to what's already out there so things don't have to get duplicated, because what we want to do as well is obviously standardise on the understanding that there's going to be some localization. So please do contact us. At the end, we will be flashing up our email, because something done in one ICS could perhaps be potentially shifted and lifted into another ICS. So, yes.
There's a really great question from Vicky Ashworth, which is about the patient. And I know this is a presentation for primary care, but what about the patients? Have we thought at all about how we're going to give patients understanding and control what 3 and 3 is, what it means for them, and so that they become part of the solution? I don't know if any of the panel, Vasa, do you have any thoughts about that? Getting the patients involved.
Music to my ears. I am a passionate believer in the concept of self-care, and we really need to empower and encourage our patients. We doctors don't speak Greek and Latin anymore. We speak English, and we can also translate to other languages. So we need to give them the power to look after themselves. And if we did that, we'll actually create some spare time, which none of us have, to spend on those who need more time from us, to do our outreach events, to spend 20 minutes with someone who doesn't speak English. We need that time, but we won't find that time unless we go down this journey. So I'm all for leaflets, apps, whatever it may be, that people mark their own homework and then say, Doc, you haven't optimized your blood pressure yet. It's this. Or the clinical pharmacist or the nurse challenges when we become complacent, because every nephrologist knows that they send me a letter to control somebody's blood pressure. 6 months later, patient comes back to nephrology clinic, the blood pressure is not controlled, the amlodipine is still at 5, the ramipril is still at 1.25. Not for all patients, but for some patients. Now, if patients knew that what their homework should be, they'll be pushing me along in that 6 months to get them home. So that when they see you, Kieran, you'll be saying everything is fine.
Sinead.
Oh, Linda, sorry. It says Sinead, but I am actually Linda. So don't forget as well, what we have in the LKN is the patient partnership group. And that's fairly new, but it's making some good progress. So we're making sure that our patient partnership group leads working in the ICSs to see how we can make patients truly involved in what we're doing and the heart of everything we do. So at the moment, they are organising, as I said before, the planning, the design and delivery around getting patients involved in self-management. So we've got the pathways, we signpost to the self-management, and now one of our next steps is making sure that we hear that patient voice and we react and adapt and do our best for them, because obviously they're the ones that matter the most. Otherwise, we wouldn't be doing what we're doing. So we have our patient partnership group guiding us as well. And in North West London, we're also collaborating with the ARC, Applied Research Collaboration Group, who have a really good patient partnership group as well. So also liaising with the different charities and other networks like the diabetes networks who have good experience around this already. So not just our group, but learning from other groups as well to make sure that patients are definitely threaded through everything. Thanks, Andrew.
another very practical question, and I'm going to come now to Kat, who volunteered as the coding expert. But obviously, we've all agreed that coding is important. And I have great sympathy for this question. Are you going to need to change the coding with every change in GFR? And it doesn't include there, of course, the ACR. So this is from Annie McKellar. It's not just the GFR, it's the ACR, of course, changes. Some patients will fluctuate. How do we best manage this in primary care? Because otherwise we're giving this primary care this almost constant moving target. Any thoughts?
Thanks. I think it's an excellent question. I think it's a difficult question. And I think it's a question that we need to take a consensus view on. And one of the other aspects to the programme is that there's actually a subgroup looking at coding chaired by Neel, who sadly is not here today, but had his video presentation involving representatives across primary care to really discuss this issue, because there is a purist perspective, isn't there, in terms of validity of coding, and then, as you say, there's a infrastructural and delivery and logistics component to it. I think what is important is that we all need to agree a certain set of defined codes. I think my personal perspective is that the QOF coding obviously would make intuitive sense for us to be using. The slight difficulty is that the current QOF coding doesn't reflect back to the earlier stages that we really want to start to capture. And so that would be somebody who's essentially got normal EGFR but has albuminuria. So I think we are going to have to be my personal perspectives, I think we have to be more nuanced and go back to G1, A2 and then filter down to G5. One of the aspirations I think that I would have is that there will always be local kind of variation and innovation. I think that's really important, and that's actually a premise of the LKN as well, to support that. But I think what we can do as a network is agree what some core standards are in terms of those measurement characteristics, and then frequency of monitoring and how you would then adjust the codes going forward. And so I think we will have to look at that granular coding. I think it would be graded in CKD G1A X as it would be and downwards, and I think we need to agree pragmatically across the network of, you know, the monitoring guidance is suggested and supported by NICE, how that's implemented, and then how we support primary care teams infrastructurally to keep the coding up to date. Vasa, you may have more insights than me.
You're on mute, Vasa.
Sorry, Andrew. Yes, Kat, I think, yes, in pure science, we like coding to be perfect. But during COVID, all of us learned that perfect is the enemy of action, that we had to be pragmatic, we had to be practical, and we got to do what we got to do. And this is about saving lives. This is not about being perfect. And therefore, I think we just need to reach consensus. I'm not a coding guy, so let the coding people in the subgroup work things out. Let's reach consensus and let's get moving, because we can't be paralyzed because we can't decide what codes to use. That will be unfair to our patients. And that's what we're talking about today. Not about making life easy for me or you. It's mainly about patients and how do we do justice to them? Because we promised them something during the vaccine program, during COVID. I went on vaccine outreach programs, talking to the public, and I promised them that I will change the way I conduct myself clinically and as a person. And this is an example of not being fixated on stuff, being practical to do what they require, not what I require.
And I think, just to come back, I think the reflection for me is just to try and shift things back to that earlier stage, isn't it? Just reflecting back the importance that we've put across, you know, on albuminuria that wouldn't necessarily be captured so easily in the systems at the moment. Thanks.
Kate, a very quick question, because we're coming towards the end. But this is an obvious question I expected, which ASARB and which SGLT2 and which statin are we recommending as first line, if any?
Ramipril 5 milligrams to start off with, not messing around with 1.25 or 2.5 unless there's an obvious reason to. 5, and then dapagliflozin 10 milligrams once a day, and atorvastatin 20 milligrams once a day. That's my toolkit that I go to. Hopefully, I think everybody's in agreement.
Thank you very much, Kieran.
But whatever one works for you, whatever one the patient's taking, whatever one the patient takes before, whatever according to license. So we are very purposely agnostic because we want to get on everyone on evidence-based medicine, not the one. If there is only one drug that fits that patient, then that's the drug for them. But as with all these things, there are lots of potential, choices, and I think we would leave that up to you and the patient and whatever you're most familiar with. I know there was some questions about ramipril dosing in more advanced CKD, 5 being the maximum dose. You might want to consider other such as irbesartan, which obviously is independent of GFR, but whatever is easiest for primary care.
That too.
Kieran, can I, just to close the questions, ask you a very straightforward, well, it's not that straightforward a question. What do you think would happen? What's your vision? What's going to happen if we fail to make this impact?
If we fail to make this impact, more people will die of premature cardiovascular disease. More people will be comorbid, so will cost the country more money. Patients' quality of life will suffer. We will have more people on dialysis, perhaps, although equally people might not survive to dialysis because they might die of cardiovascular disease from the lack of these agents. These things are unimaginable in a 21st century healthcare system when we know the great evidence of these trials. So I don't want to focus on what happens when we fail. I only want to describe what happens when success looks like, and that's the right people getting the right medicines at the right time across the board.
Kieran, can I thank the panel? We've got a hand up. I'm not sure if we are able to unmute them. Is that presumably for a question? Sinead?
I can see if you're happy. If we have time for one more question, so I'm mindful that one question, great. So we've got a question from Rumit Shah, and I'm just going to allow your mic, Rumit, and then you should be able to unmute yourself. I don't know that I can give you a camera. I'm not sure I have that capability. Do you want to try and unmute yourself?
Okay, it may not technically work. Rumit, please put it in the question Q&A. I promise we will make sure you get the answer. But I want to thank the panel and the organisers, and I want now to go back to Kieran. I think you are going to
I'll bring up the slides, Kieran. One moment. It won't take more than a second.
So thank you very much, everybody. I think that was a fantastic joint group effort. Hopefully we've energized you to go away into wherever you work, into your communities. Next slide, please, to deliver the messages that we've had here. Just waiting for the next slide.
Yeah, sorry, it's just frozen. 1 second.
That's fine. So there are 6 things we want to take home. The 3 things we want to get a hold of is proteinuria is important as an early identification for chronic kidney disease. Is that might be so we want to hear your feedback. So if you scan that QR code, and that will take you to the feedback link. We'll also, I think, be emailing you out feedback links. So it's really important that we hear from you whether you thought it was good or bad and how we did. So the things that we learned are identify CKD early by urine ACR testing. Waiting for the GFR to fall is too late. We need to get the medication to the right people at the right time to prevent them developing worsening kidney function, and we need to do it now. It's such a golden opportunity for patients. Massive numbers of people across our population can benefit from these ways of managing patients. So what do we do now? So as Linda said, we need to spread the word about the LKN, its pathways. We're here to help. We're here to support you, troubleshoot. But we also need that. It's a group effort. We need you. We can't succeed without your help in primary care, in your clinics, in your surgeries, with your pharmacists, with your nurses. Email also the LKN or contact your LKN primary care rep to any problems, and really get involved. And we're always keen. If you want to help, we want to get involved. We're keen to hear from you. So thank you very much, everybody. Thanks to all the speakers. Thanks for all the questions. I look forward to the new chapter of Managing CKD in London 2022. Thank you very much.
Thank you, everyone.